So welcome to Dr. Gonzalez. He is the Director of Family Medicine Services at Lored Health Center. A little bit about his career. He's a board-certified family physician, serving as Lored's Health Center's Director of Family Medicine since 2017. He manages the day-to-day operations of the family practice and is fluent in both Spanish and English. Before joining Lored, Dr. Gonzalez was a faculty member at Mount Sinai Medical Hospital at Bronx Lebanon Hospital in New York, where he mentored residents and medical students in both inpatient and outpatient care. And we would like to welcome Dr. Gonzalez, and we're going to let him take it from here.
Thank you very much, Christy and Tim. It's a pleasure to be with you guys. So let's start with the first slide, please. And that's okay. All right. Thank you, everybody, for being here. So I guess the next slide. All right. So before I go into this slide, let me tell our audience that we can divide medicine in multi different ways. We can divide it. And one way that we can divide medicine is outpatient medicine or ambulatory medicine and inpatient medicine. So, and the difference is that the ambulatory medicine, which what we do, the outpatient medicine, is the medicine that the main goal is the prevention of the diseases, or the prevention of the progression of diseases. The hospital medicine, which is extremely important too, is the one that we do in a hospital setting. Those are the patients that their condition has evolved into a certain level of complication that require the patient to be in a hospital setting to receive certain type of care. But the outpatient medicine, which is what we do, is the main goal is the prevention of diseases or the progression of diseases. And then again, inside the hospital, you can take care of acute and hyperacute conditions. Sometimes the condition evolves into the critical care condition. But eventually, when the patient is discharged, is sent to the primary care doctor, which is what we do here. We do primary medicine in this institution. So because that's what we do, we listen, we meet the patients where they are. We educate the patients on how they can improve their health. And I want to say in terms of that, the meaning of the word doctor is to teach at the highest level. So anybody that likes to teach, anybody that, and on top of that, is compassionate, has empathy, he has what he needs to become a doctor. So we give patients the tools to treat and manage chronic diseases such as diabetes, heart disease. We promote prevention, lifestyle changes, and this, but it comes after that we can provide this 340B pharmacy plan. This is a unique feature that we have, which with certain partners we can send a prescription to certain pharmacies that participate with the 340B plan, and the patient can get the medications at much lower price. Really incredible. I can tell, for instance, there are medications that can cost $1,000, and the 340B plan can be less than $100. So, and we can do that in this institution. And obviously, we can make referrals to specialties and act as a trusted source of healthcare information, and train other providers to offer the best care possible. In that part, we now have been in collaboration with Bay Health, and then we have residents to come to rotate with us. The residents are doctors in training that they come to the red and have a rotation that they call the FQHC experience, because we are a federally qualified health center. Next, please. Okay. Next, I think there was a one prior to the last one. I'm not so sure. There's something prior to this one. Oh, no. Then keep on going. Next. Okay, this is why become a family medical doctor. And well, there are many reasons, particularly in my case, there are many reasons. So as I say, so the family physicians, the internists, the pediatricians, the OBGYN doctors, the psychiatrists, the behavioral providers, the dentists, we are the first line, and we are the one that provide services in an ambulatory base, but also we are the one who provide preventive measures, medical care to all these patients to try to prevent the progression of the diseases. So, and again, you know, if whomever is in here that like to help people, if you like to help people, if you like to teach, you know, and on top of that, you have empathy, then you have the right ingredients to become a doctor. You change people's lives. Most chronic illnesses can be prevented just by making lifestyle changes. A family doctor or a primary care provider can guide you on how to make changes and improve your health and quality of life. Family medical doctors are trusted partners of information. And again, I mean, it is important because, as I say, we not only provide the medical care, but we also provide guidance and education to the people that come to us for services. So the family medical doctor is the conductor of the care. Next. Next one, please. I want to say that, you know, we are a federally qualified health center, and for that, there is a rigorous process that the institutions that get this have to go through, and that's done through the National Committee for Quality Assurance that exists only with the purpose of increase the quality of the institutions that are qualified by them. There are other aspects of this that need to be, you know, there's certain benchmarks that we have to meet to be able to get this qualification, and we have it, and also we have to be able to demonstrate that we provide services not only to people with insurance, but also with people that are underinsured. Next, please. Next. Okay. In this clinic is a big clinic, and we see here pretty much any condition in the ambulatory setting that is seen in a teaching hospital, literally any condition. The bulk of those patients, I mean, La Red Care cares for just under 14,000 patients, and the bulk, some 11,000, are in our primary practice. 34% of our patients are under the age of 18, 55, between 18 and 64. 31% of the patients have hypertension, and 14 of the patients have diabetes. So this is a lot. I mean, but again, we provide services above and beyond. And we are not only a federal qualified health center, but we are also a patient-centered medical home. This is a concept that was developed by the pediatricians, I think in the 70s, but it was taken from them by the family physicians, I guess. And basically what it means is that a patient-centered medical home is an institution like ours in which a patient can get simultaneously all the levels of primary care that he needs to and all the levels of preventative measures that can be applied to this patient. I'm going to give an example. For instance, if a patient comes to see me and the patient has, let's say, hypertension, but the patient has had some sort of a trauma and go into a crisis, then we can right there call behavioral medicine and the crisis team, and the person can be taken care of and transferred to, let's say, the psych unit if he needs to. And same thing, for instance, if a patient is in dental and all of a sudden the patient starts to say that he cannot breathe, we can go there and take care of the patient and find out what's the reason the patient cannot breathe. It's a pulmonary problem. It's a cardiac problem. It's an emotional problem. And we can provide all the service simultaneously to every patient that comes in here. That's the beauty of being a patient-centered medical home. Next, please. Okay, so what does it take to become a doctor? Well, it says here, work hard in high school. So yeah, you work very hard in high school, take science, math courses. I guess nowadays there are many things that can be done. There are courses that are offered from some institutions to students that are interested in them. I guess some of them you require to have certain grade at school, but still you have access to. And for instance, the people at Johns Hopkins, they offer a training for high school students. And I know that because my daughter participated in those. If you're a very good student, you're interested, there are a lot of sources or resources that you can use now that we didn't have in our time. But you guys can take advantage of that because, for instance, that class in Johns Hopkins was a week, and they teach you, basic care of the patient. You learn how to do searches. You learn how to put, IDs. You learn how to do CPR properly. So things of that nature. So this is a lot of resources out there. If you are really interested, in the earlier, the better. And the MCAT, and do the best you can. Like any other test of that type of test is a test that require that you invest yourself to do the best you can. And medical school typically is 4 years, and after that you have to go for a training, a residency program. Like I was training for around 4 years. It can be 6 years. It can be longer if you want to. I know some people may be concerned because they say, hey, after I finish medical school, I have this tremendous debt, and now I'm going to go 6 more years training. How am I going to pay? Well, the good thing is that when you're training as a resident, you're being paid as a doctor. And of course, the payment is based on your level. The first level of the residency, you're an intern, we call it. Your payment is the lowest level because you don't know medicine, and you're gonna be trained, but still you have a salary, and a salary that allows you to rent an apartment, to buy a car. So, and as you increase as the year pass and your level go up, then also your salary go up. And like for instance, the salary between a first year resident, an intern, and a person that is in the 6th year because he's finishing cardiology is very different, And the average salary says here 255, but those things are always 255,000. But those things are always negotiable, and depending on the place that you go. Next. Oh, how can I pay for a school? Well, Delaware is a medically underserved community, so that it means that that means that there are programs available to help defray the cost of medical school. In fact, that happened at that level, but sometimes after people finish their training as a doctor, if they're willing to come here and practice, some institution may take care of your debt, because we have a problem here in Southern Delaware. We have a problem of retention. So some institutions can have years without being able to capture or to hire a physician working here. So for all of you that are interested, really there is I guess a lot of space down here for young physicians that wanted to come and practice down here. So it's also what's called the HRSA, offer student loan payment programs that can offset the cost of medical school anywhere between $30,000 and $100,000. So, and HRSA is the Health Resources and Service Administration, and it's an agency of the Department of Health. And I want to say that it's a primary federal agency to improve access to health for people with that have difficulties to have access to health. HRSA exists for these people too. Next, please.
If I can interject, my
Yes.
organization, the Delaware Academy of Medicine, also provides student financial aid to physicians, dentists, and then with ARPA funding to nurses, dental hygienists, pretty much the whole shooting match, because we have fairly acute shortages. So as Dr. Gonzalez says, there are a lot of resources that we can bring to bear. So finances, is hopefully not as big a concern as it used to be. Sorry, thanks for letting me interject there.
Oh, no. Thank you, Tim. No, and it is important because, one of the things that everybody going to consider going into this career is how much it's going to cost me, and then how am I going to be able to pay for this? And it's good that everybody knows that there are resources to help with the payment, but also, again, after you finish your training, you may, negotiate with an institution able to pay whatever is your debt, as long as you, let's say you're able to stay, I don't know, maybe a couple of years, 2-3 years with the institution, something of that nature, but your debt will be almost completely paid. Just what are my job prospects? And I already said it, right? So there are a great need of physicians in Southern Delaware. We want, all you guys are interested in studying medicine and to do your best, because there is positions here that need to be filled, and hopefully you guys going to be the one doing that. Because Delaware, particularly Sussex County, has a great need for family doctors, and the population is growing, so we're going to need more. Okay, next. Okay, what would you like to know? I can do a quick presentation of a patient, a typical patient. Maybe we can do two typical patients that come to Lorraine, and I think it's important what I'm gonna present to you, because it tells you, what we do here and what we can do here. That probably, almost certainly, let's say a private institution will be more difficult for them to be able to do this. I'm going to give you I'm going to present a case of a patient with diabetes. You have diabetes type 1, and you have diabetes type 2. The diabetes, type 1 is the one that the person is born with this condition. The diabetes type 2 is the one that is inherited. And usually there is a history in which the mom and uncle, the brother has diabetes in the family. Sometimes the whole family. I'm talking diabetes type 2. And And unfortunately, but it's true, there is an association with diabetes type 2 and obesity or being overweight. So anyway, a typical case, a patient is let's say, 40-year-old male with a history of type 2 diabetes mellitus, hypertension, dyslipidemia, which means that there's a problem with cholesterol, uh, gastroesophageal reflux disease, and obesity. And you can classify obesity type 1, 2, and 3. I'm going to make it type 3, meaning that this patient has a body mass index, let's say 40. Person weight, I don't know, 280 pounds or something like that. So the patient has type 2 diabetes, hypertension, dyslipidemia, gastroesophageal reflux disease, and obesity. But the patient comes to the clinic for a follow-up of his diabetes. And when the patient comes, the finger stick is unreadable, meaning that the blood sugar can be above 500. So there is something that we can do in the house is called A1C. And the A1C or glycosylated is a test that we do that help us to have a better idea about how is the diabetes or the blood sugar in this patient has been in the last 3 months. This is something that we do every 3 months. And why is important? Because when everybody eats, the blood sugar is going to go up. And if you eat tres leches and you eat bizcocho and you drink soda, at that moment, your blood sugar is going to be super high. But the difference between a regular person and a person with diabetes is that in 2 or 3 hours, this blood sugar is going to come down. The person with diabetes, the blood sugar is going to go up, but it cannot come down. And the reason is because there is a substance, a chemical in the body, it's called insulin, that probably is poor quality or is not sufficient to do the job, which is to take this sugar and put it inside the cells to be used as a fuel. That's what the insulin mainly does. It takes the sugar, put it inside the cell as a fuel. But because it's poor quality or it's too little, it cannot do its job, and the blood sugar accumulate. So this A1C is helpful because when you do that, it tells you a little bit more about the story. Normal should be, let's say, around 6. But if it's 13, for instance, you know that this 500 or above 500 is real. And then you go and talk to the patient and ask if he's taking his medication. And probably the patient is going to tell you, not really. Some people don't understand, which is one of the things, what I said before is important, is the aspect of teaching. So, and explain to the patient his condition. Sometimes they don't understand. Sometimes some people do resistance. Some people are in a denial in terms of their condition. So anyway, but the bottom line is, in any typical day, this blood sugar in 500 is a consideration for admission of the patient in the hospital. It's a consideration because this patient can develop something called diabetic ketoacidosis and go into coma and die. However, we have this situation in which we have to put in a balance. If I send the patient to the emergency room, right, that will have a cost of maybe $5,000. And I know what they're going to do. They're going to give fluids to the patient. They're going to give a little bit of insulin to drop this to a more manageable number, but still high, maybe in the 300s, and send it to Dr. Gonzalez. So then one of the things that I do is I, for instance, will manage this in here. So, and I will explain to the patient that he has to come back to see me in a couple of days. So why? Because I want to make sure that my intervention will bring the sugar down to maybe in the 300 range, and then we can continue doing an ambulatory care. If in a couple of days it still remain like that, the patient has something called ketones in the urine that we check a patient said has abdominal pain, which is a sign of diabetic ketoacidosis, probably it's a better idea to send the patient to the hospital. But if the patient doesn't have those things, it's just the blood sugar is high, it doesn't have ketones, then I will treat the patient in here. We'll give insulin inside, I will give fluids inside, and then I will bring back the patient in a couple of days. And then there is a lot of education with this patient that we do. Everybody with diabetes needs to be seen by an ophthalmologist once a year. Everybody with diabetes needs to have his feet checked at least once a year, maybe by a podiatrist. Everybody with diabetes has to have pneumonia vaccine. And some people say, but why the pneumonia vaccine? What's going to happen? You want to stop the patient from having pneumonia? No. Still, the patient can have pneumonia. However, the patient won't necessarily develop the pneumonia, a type of pneumonia that can affect diabetic people, that can put them in a critical care. So then that's what this prevents, for instance, the pneumonia vaccine. Just to give an example, all these things we can do in here. To give an example, the what's called point of care, which is the checking of the A1C, in some or in many private practices, they don't offer that. They do it like we used to do in the olden time, which we order this, the patient go to the lab, they do it in the day before, we check how is A1C. Here, for instance, we can do this on site. Now we have something new that we have in here too inside, which is the examining of the retina of the patients with diabetes, which, as I say, has to be done every year because there's something that we try to prevent, because of what we do, preventative medicine, which is that the patient has something called diabetic retinopathy and ended blind. So we have to send it to the ophthalmologist, but now we have the means to examine the retina with the special equipment that we have in here. As this is because I was asked for any, a typical day, that would be a typical day here. This is a patient that in any other institution will be referred to the emergency room. We need to assess the best we can this patient and provide the best care we can, because it's not only the care that he needs at this moment, but it's also a bill that he may have that is going to be very difficult for him to pay. So I'm going to give another example, and that happened yesterday. It's a very good example. We have here at Lared, we have a mobile unit. We have a mobile unit, and that unit, is to provide service in different areas here. And there are maybe people that are far from us, and it's difficult for them to come here. And yesterday, I received a phone call by the provider that is in the mobile home, to give an example. And she said that she has a lady, I think is on her 80s, and the lady was having, the heart rate was low, and she did an EKG. She wanted me to see the EKG. So that's the beauty, right? She was remote, but she was able to send me the EKG. So, and I see, the electrocardiogram I saw. And before I continue, let me say something quickly here. Let's stop it in there. And it's because I remember Tim want me to talk a little bit about maybe a system. Before I continue about this case that happened yesterday, of the lady with the heart rate that was very low, very slow. Let me talk to you a little bit about the heart. I'm going to say something, I guess, very basic. The heart is a muscle. It's a very strong muscle. It has 4 chambers, 2 on top and 2 on the bottom. The chambers on top are the atria, and the one in the bottom are the ventricles. So the purpose of that muscle is to basically to pump the blood around the whole body, and by doing that, it provides the oxygenation that all the structures of the body needs to survive. We need oxygen. Every cell needs oxygen to be able to survive. And that's why the heart is extremely important, what it does, which is pumping and distributing this blood to the whole body. So anyway, there are the structure of the heart is not only muscle, but there are embedded of this muscle there is a circuit that we can say is an electric circuit. It's not really electric, it's because the conduction is through chemical signals, through sodium, potassium, but it's a little more complicated. I don't want to go there. But this electric system is the one that, commanded by an autonomous point in the right atrium on top, called sinus node, triggers spontaneously, automatically, and causes this pulsation to go through the heart, and the heart will do his job of pumping. So there are diseases that can affect the muscle of the heart. For instance, if a person is an alcoholic, this can cause something called alcohol dilation of the heart, right? It can happen if the heart doesn't pump properly. But also the muscle can be affected if the vessels that bring blood inside the muscle of the heart are blockaded. And that's what it is, a myocardial infarction. Myocardium is a term that refers to the muscle of the heart. And infarction means that the blood, the flow of the blood has been blockaded at a certain point. If that happens after the blockade, the cell will die. That's what is a myocardial infarction, or MI. But also the heart, the structure that produces the conduction, can be impacted for multiple reasons. And there are different ways to call these diseases. And one of them are blockade. A blockade means that in this case, that the impulse, a certain specific point in the heart, doesn't traverse the way that should be, and that will affect the rhythm of the heart. Because remember, this rhythm of the heart depends on this spontaneous node that is on top of the right atrium. It's called sinus node. And then if at some point in all this system there is something interfere with the conduction, the heart not gonna pump properly. Anyway, going back to this lady, they sent me, thank you. And they sent me here you see the heart, and the two atrium on top, the ventricles on the bottom. And then from the ventricles, you have two different vessels. From the left ventricle, you have the aorta, which is in red, which is the oxygenated blood go through the whole body. But from the left ventricle, you have the pulmonary vessel that basically take the non-oxygenated blood to the lungs and is oxygenated to return to the heart. So that is what is called the small circulation, if you will. So I'm going to say it again. The heart, the blood comes from the whole body and go to the superior vena cava, here in blue. From the superior vena cava, go to the right atrium and eventually to the right ventricle, and is pumped to the pulmonary arteries that you can see, one to the right and one to the left. That blood doesn't have oxygen. That blood goes to the lungs to get oxygenated, and then return to the pulmonary veins. This is a change of circuit, and enter to the left atrium and eventually to the left ventricle. And from the left ventricle, this oxygenated blood is pumped to the whole body. Anyway, in here, the electric system is not depicted. But what I want to say was, as I was saying, yesterday, I received an electrocardiogram from this lady in real time, and I was asked what to do. Well, the frequency of the heart was below 30. So what I said, she has a complete block, and she has to go to the hospital immediately. And guess what? We sent the lady immediately to the hospital, and they were able to put a pacemaker on her, and she's doing very fine. But she could have died last night. So, and those are the things that we can do here at La Red. So, and with that, I'm all ears for your questions.
Let me
Alrighty.
get myself off of mute here and let me stop sharing. I felt like I was a member of the flight crew just now, kind of directing people with the mouse, and you were doing the instructions. All right, let me stop sharing. Doctor, before we get to the questions, I wanted to ask you one question. The sort of the first case you talked about, you mentioned about diabetes, and I think the statistic said that 14% of the patients at Lorette are pre-diabetic or diabetic. What does that actually mean? Everyone has heard of diabetes probably, but what is diabetes?
But what is diabetes? Okay,
Yeah.
first, I mean, there is 40 million people with diabetes in the United States. I think it is, and growing. It's really a problem. Diabetes is a disease, it's an endocrinologic disease. It's a disease basically in which an organ called pancreas either does not produce or produce too little or produce a poor quality substance or chemical or hormone called insulin. What is it the insulin does? The insulin basically, what it does is that carries the glucose. The glucose is the name of the sugar inside the blood. The outside is carbohydrates. So the insulin carries this glucose, these particles of glucose inside the cell, and the cell uses as a fuel. And it's very important because we have other sources of energy in the body, but to use them, using the glucose is more efficient, is faster, you know. So exactly, it's more efficient, it is faster. So when that happened, that the pancreas is not properly producing insulin or is poor quality, this glucose no longer can be uh, placed inside the cell as a fuel. And what's going to happen is that this glucose going to accumulate in your body and will cause a lot of problems. It can cause damage in your vision, so we call diabetic retinopathy. It can cause damage definitely in the endings of the nerve fibers. So people are going to have problems of proprioception in the legs, for instance. Some people can have a condition called paresthesia, which is they have a lot of sensations, tingling sensation, numbing sensation of the legs. It's because the blood sugar has been damaging the ending of the nerve fibers there. In fact, one of the problems with the diabetes is because it does that. Some people can have silent infarcts, myocardial infarction. Believe it or not, the pain can save your life. If you have pain in your chest, you will think maybe I have a problem here and you will look for help. But if you don't have any pain, you're not going to know. So that can happen to diabetic people. They have what is called silent infarcts. And diabetes is the number one cause of kidney failure in the United States. It's the number one cause. If you go to a dialysis center, 93% of the people in the dialysis center are there because of diabetes uncontrolled for many years. So the majority of the people in dialysis centers are not there because of kidney problems. There are a subset number of people with kidney problems that can end it in the dialysis center, but the vast majority, 92%, maybe more, is because of uncontrolled diabetes. So yeah, I guess in a nutshell, no?
Yep. Yep. Thank you very much. So a drug like metformin, which a lot of people have heard from one of the original front lines, how does that work?
So metformin is a drug that has been in the arsenal for many years, forever. I mean, everybody in diabetes has to be on metformin somehow. And the metformin will help metabolize the blood sugar and will also will work in the liver, because in the liver you can produce glucose and will reduce the amount of glucose that can be produced in the liver, but also will make the muscles more efficient to capturing the particles of blood sugar. And by doing that, the blood sugar tends to go down, and it does it in a very slowly. There are some side effects also, like any medication. It's important to know that there's no innocent medication. I remember a teacher, a professor told me once that doctors basically are not doctors, but risk managers, because every time you prescribe a medication, there is risk involved. And for the metformin is no different. Metformin, the main problem with metformin at the beginning of the use of this medication, it will be diarrhea. Everybody going to have diarrhea with metformin at the beginning, but the body adjusts. And other problem with metformin is something called lactic acidosis, which is a little bit more serious. And you can see in people that have some degree of renal failure. I guess we see these less and less nowadays.
All righty. Well, let me go to the first question. I've got to find where I put it. So this gets back to medical school and residency and stuff. It'll take you back here, doctor. Can you take a gap year between medical school and residency, or is that not recommended? Here's a whole opportunity to explain the match program.
Oh, a gap. Well, I would say that depends on what is the gap for. If let's say that you want to go as a volunteer with Doctors Without Frontier, and if you want to do something like that, I would say go for it. As I guess, as long as you still have, or you get some input in terms of this, and you continue developing some real skills or experiences, I would say go for that. But if you're going to completely, let's say, divorce from it, if you wanted to have a sabbatic because you want to go to, to play, your guitar with your friends and go to Woodstock or something like that for a year, then I don't know if that's a good idea, because like in any science, all this is cumulative. I mean, you start studying. I remember when I studied biology, right? When the teacher of biology start, is a little. And if you don't pay attention in 3 days, it's almost a book. So, again, if you say, okay, I'm going to go with Doctors Without Borders to work in Somalia, you're going to be with these training doctors, or you're going to go to some scientific process. I mean, let's say, well, I want to go into, I don't know, molecular biology or study genetics for a year, full blown, because you get a grant or somebody going to help you, then go for it. But again, if you're going to do something completely different, then you're going to find very hard when you return,
And I would say that another way to express it is that medicine is frequently about momentum. That once you've gone through medical school, you might be tired. However, if you do, get matched the first time to a residency program, just about everyone takes that, unless, as you say, there's something like Doctors Without Borders or Doctors Without Frontiers, some compelling alternative. Unfortunately, there are some people who don't get accepted at any residency program in the first year, so they have to take a gap year. And then the challenge is to keep your momentum going and remain gainfully involved in some aspect of medicine. So that's a really good question, and there's some subtlety to it.
Tim, if I may, for those people that are not able to get into the residency, and when they at the beginning in the match or whatever, volunteering can be helpful. So you go to volunteer in the hospital, you volunteer in the clinic, that can be helpful in the process, because there are many people, many directors that they value those things. They will value that, and they give you an opportunity, right?
Yep. All right. So, doctor, if you look at the bottom bar, you'll see where it says Q&A and the number 12, meaning there are 12 questions. Do you see that?
I see the 12, yes.
Yeah. So if you open that up, you can tackle those questions, or I can ask them to you, your choice.
Okay. Well, just what is the most important task you complete? Well, I'm gonna, let me see if I can. Again, what we do here is ambulatory medicine, primary care medicine, preventive medicine, and education. I'm going to give an example about uh, preventive medicine, which I think is not everything that we do is important, but this is something that I will give as an example of things that we do here that are very important. The screening, for instance, the screening. What is a screening? A screening is a test that is done in somebody that doesn't have a person doesn't have any symptoms of any disease and doesn't have any complaint of any disease. Okay, so a screening is done in patients without complaints and without symptoms. But what is the purpose of this? The purpose of this is to prevent certain diseases, and specifically certain type of cancers. Now, we do that here every day. I'm going to tell you how, more or less how it works. If a young woman comes and she is 21, and I follow the USPFDS task force, but there are many different institutions that make recommendations in terms of screening methods. If a young woman is 21, then we need to have a conversation about a pap smear, right? The recommendation is from 21 and up, every woman has to have a pap smear. And you will ask, why not before 20? There is something in the body of the woman that we still don't know exactly what it is. But before 20, women's body can clear itself from the virus of the papilloma virus, which is the one that is implicated mostly in cervical cancer in women. That happened before 20. After 20, that doesn't happen that way. So then we implement this screening method because if there is any changes in the cervix, we effectively can prevent this woman to have cancer of the cervix, which our grandmothers and great grandmothers used to die from, and nowadays is less and less common. I'm going to give you another example. The same woman. Now this woman is 40, 41. Not only have to make sure that she have a pap smear, but also have to make sure that she have a mammogram screening, to make sure. Why? Because through studies, we know that the incidence of breast cancer from that point increases. So we do mammograms. Some organizations like the task force says every 2 years. Some other institutions like ours says once a year. But anyway, in that way, is for the prevention of breast cancer. And multiple women doesn't have anything, but we're gonna find, because still we found women that we catch, breast cancer very early, thanks to these procedures, and then she can go for a lumpectomy, which means it's only the area of the cancer that is removed, a mastectomy if it's too big, a mastectomy and removal of lymph nodes, radiation. But there is a myriad, no, not a myriad, but many modalities that can help this woman, but especially even in a screening for breast cancer, we very early detect that. I'm going to give another example. The same woman, now she's 45. Not only I have to do the pap smear, but I have to do the mammogram. but now this woman has to have a colonoscopy, you see. And I'm going to give you another example. A person, I don't know, about 50 that has smoked a cigarette, a pack of cigarette daily for 30 years. You know, this is a person that gained in terms of prevention, what is called a low dose CT scan of the chest, we use to pinpoint lung cancer. So yeah, so those things are some of the important things that we do here in this institution.
All righty. And then what do you like most about being a physician, which is the other half of it? There's the important stuff, and then there's what do you like about
Everything.
it?
Yeah, I really enjoy what I do. Let me tell you this. I'm gonna say it. Growing up, I I used to work in an orphan as a teacher of little kids, right? And then at the university, you know, I was able to earn a position to be to assist one of my teachers, one of my mentors in the pharmacology lab. So I was the one who assembled the labs, who picked the rats, who inject the rats, and that kind of stuff. And so, and you can see what I just explained to you, the way that I explained to you this screening, I guess it showed not only a passion, but the, you know, if you will, I guess happiness of being able to do this. You know, I'm very honest. I'm very happy here at the Red. Everybody is very, very nice, very respectful, and you know, we have a wonderful team of people working from the administration, you know, to our, you know, a chief medical officer, Dr. Alarcon, Dr. Santiago, which is the chief of pediatrics, and we all work together. So, and then you have the opportunity to educate the people. You have the opportunity to educate or every step of the way. Sometimes it works, sometimes it's more difficult. Yeah, but I enjoy my job.
Right. And speaking of Lored and it being a federally qualified health center, one of the questions is, due to your location and services, do you notice an influx of seasonal farm workers as patients?
An influx of
Seasonal farm workers?
um, well, we can have farm workers, definitely, but we also have the workers of the chicken plant, and we have many of those. We can have, but listen, we have pretty much everybody is coming nowadays here because we provide a good quality service to a very reasonable, if the word reasonable is reasonable in this case, a reasonable price, a very good quality of services. Like for instance, you know, we have, to give an example, we have something called Screen for Life about screening again. It's important. And Screen for Life is a grant in which we can provide all these screening methods at almost no cost. You know, of course, there's always, you know, a cost. We were at some point participating. I don't know what happened with that. I'm going to follow on that. We were participating, I guess, with the institution in New York that were providing us don't quote me on that, but we were getting the next plan on. And of course, the next plan has a cost. You know, of course, it has a cost. And, you know, but we were able to use it in the young population that wanted to prevent pregnancy at a very, very low cost, you know. And so people will say, yeah, well, but, you know, you'd rather want the prevention. Again, that's what we do, right? And so, yeah, there's so many things that we do here that is unbelievable.
All righty. Let's see. I'm going to divide these questions up. So we have some questions about the heart. We'll do the first one here. I heard that the heart has neurons. is there any disease that affects the neurons of the heart, but not the muscle part of the heart? Or do these diseases primarily target the tissue of the heart? Do with that what you will.
Yes. So there are diseases that can affect the the conduction system of the heart. Like for instance, there is something called tachybrady syndrome, in which the sinus nodule doesn't trigger uh, with the uh, automaticity that should be. It can go fast and suddenly it goes slow. You know, there are other diseases of the conduction system that can be because there is an aberrant uh, 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 brand that shouldn't be there, right? You know, the conduction system, it triggered in the sinus node, and the impulse go down, you know, to the another node that is between the atria and the ventricles, and then to two branches called the His, the as of His, right? And this is this structure is in a certain way, but if there is an anomaly that the person has an additional brand that shouldn't be there, this branch will also conduct the impulse, but then it will trigger, you know, in a way that may not be, or it is not in consonance with the rest of the system. Yes, it can help.
All right. Do you have or know any patients with the condition hypoplastic left heart syndrome? So first off, what is that? And then do you have any patients with it?
Well, the term this term hypoplastic. So you have hyperplasia, um, which is that let's say, to make it simple, the organ will become bigger and hypo will become smaller. No, I don't deal with this because when these conditions happen, uh, the patient most probably is probably in the infancy, and the patient most probably going to be in the hospital. So yeah, no, with these kind of conditions don't reach to us. No.
All righty. Let's see, anything else about the heart here? Okay, let's do some more diabetes questions. Talk to us about having diabetes and wounds or open sores.
Yeah. Um, well, the diabetes, unfortunately, one of the things that happen when you have diabetes is that there is usually an accumulation or a higher level of glucose in your body. The glucose is a good medium for certain bacteria to grow. And as I say, the the um, the blood sugar will damage the small nerve fibers. These nerve fibers also has to do with the effective function of the blood vessels. And when all these systems are somehow altered because of the disease, then it's more difficult for the patient to heal. And sometimes, because of what I said before, they're prone to have infections in the wound. In fact, which I don't think I mentioned, that diabetes, when it's not controlled, can prone to damage of the vessels and amputation of the lower extremities. And I used to see that a lot when I was working in hospital in New York. So yeah, so that's why our work in prevention is so important, because you don't want anybody to get there, because once you get there, you know, if somebody has a gangrene of a foot, the only way out of this is the amputation, because is dead tissue, and it's going to continue moving towards the one that is alive. So the only way that you can stop that is amputating. So very unfortunate, but that's, yeah.
Right, and part of one of the contributing factors in that is the neuropathy, where you're not feeling the pain associated with the wound. Is that correct?
Absolutely. Yeah. Yes.
Yeah.
Yes.
Yeah. So it all. So there was a question asking about the two types of diabetes, and I already answered it sort of offline to remind that there are three types. There's type 1, you're born with it. Type 2, you acquire it. And then there's gestational diabetes. So talk to us about gestational diabetes. And if a woman has that, does that increase the likelihood that she will have diabetes type 2 after her pregnancy?
Absolutely. Gestational diabetes, as the name says by itself, is diabetes that occur during pregnancy. So we use different methods to make the diagnostic of diabetes. Nowadays, we use the blood sugar. If it's fasting 126, the patient may have diabetes. Then we use the A1C. If it's below above 6.5, we'll say the patient has diabetes. But the GYN people, the OBG use actually the most considered the gold standard for this, which is the glucose tolerance test. It's a test in which certain amount of sugar is given to a person. The sugar is measured after a certain time, and if it's a certain number, you can say more accurately that has diabetes. Believe it or not, they have the most accurate method. And anyway, for immediate reasons, maybe family history or other factors, a pregnant woman can develop diabetes during pregnancy. However, after she delivers the baby, she can go back to not having diabetes. But unfortunately, there is a high percentage of probability that this woman in the future, she will develop diabetes. If she can take care of herself, she exercises, she doesn't gain weight, she stays away from carbs, she might be able to not to. But there is a number of people that after gestational diabetes, they develop diabetes. And I have some of those.
All righty. Another question about metformin and insulin here is, so what are in my mind, I might be making it more complicated in my mind than what this person is asking. But when do you start metformin? Pre-diabetes or you're officially diabetic? And what dosage do you start at? And then as you go through, and what's the upper level of metformin, and when do you say, nope, we've done what we can with metformin, now we need to move to another drug like injectable insulin? So talk to us about that whole continuum.
Yes. So metformin is like, if you will, it doesn't have to be that way, but it's to be like the backbone of the treatment of the management of diabetes. And now, can we use metformin in pre-diabetic patients? Absolutely. There is a class of people in which you should use metformin. If a patient has obesity, right? I think obesity, even if it's obesity class 1, probably you should start the patient in metformin. You don't want to use metformin like you use in a diabetic patient, but that there are some studies that states that it will prevent the patient to become diabetic. So yes, you can use diabetes in pre-diabetic patient as long as they have obesity, and usually it can be a dose of 500 milligrams. I'm sorry, once a day. You can have now extended release. You can use a 500 milligram once a day extended release. You can use 500 milligrams twice a day, but usually once a day for pre-diabetic people. The max dose of metformin is 1,000 milligrams twice a day. That's the max dose. Now we have different dosages now. You have, 650, you have 825 or 850, but the max dose is 1,000 two times a day. The insulin, before I go to the insulin, the goal should always have the diabetes well controlled. Some people, sometimes they go, but doctor, I don't want you to give me insulin, because for some people think that if I give you insulin, it's something bad for you, that the insulin gonna cause some damage to you, or maybe you can feel that defeated because I'm talking to you about insulin, and somehow if you take insulin, you're like doomed or something like that. No, it shouldn't be that way. What we need to always is to aim to have the blood sugar control, because all these complications, blindness, silent heart attack, kidney failure, gangrene, all these complications happen when the blood sugar is uncontrolled. So what we aim is always to control the blood sugar. And when we're going to use insulin, well, there's a lot of medication that you can use before getting to insulin. Nowadays, we have a lot of stuff. We have, SGLT2, in fact, there's a lot of medications. But if you're using, let's say, if you have a patient in metformin, Jardiance, and glipizide, for instance, and the blood sugar still is high, and you see that the patient maybe he partially understands, or the patient is not compliant, which is another problem that we have with many patients in many conditions. But you see that this A1C is consistently in 10 or 9 or 10. You can say, let me introduce insulin, and the aim should be at eventually take the patient out of the insulin. Not necessarily that's what it is, that the patient has to be on insulin. The aim is, after you start the insulin, to eventually be able to, of course, with the collaboration of the patient, to take him out of the insulin and just leave it in pills. But always, if you have to choose into having the patient only in pills with the A1C in 10 or above, and give the patient insulin because of what I just said, then you're going to have to give the insulin. Again, it's as I said, it's like, as my teacher used to tell me, we're risk managers, right? Because insulin is not innocent. Insulin is not innocent. Insulin is a medication that is an excellent medication, but if somebody make a mistake, you can be in trouble, because it can drop the blood sugar completely down. And in fact, I have an experience working in hospital. This is a very sad story, but it's true. This girl, when somebody has elevated blood sugar, very high or very low, the manifestations can be similar. So this girl, was hypoglycemic because she uses insulin, and she collapses. The mother that didn't know arrives, and she thought the blood sugar is high, and she gave her more insulin.
Oh,
Well, yeah, exactly. You never do that. If you don't know what happened, you need your blood sugar. You need to check your blood sugar. Patient collapses, you need to check the blood sugar, because the patient collapses and the blood sugar is, on the floor, and you gave insulin, you will literally fry the brain of that person, and that's what happened. The poor girl, and we tried all the status we could, all the solumeter we could, everything, but her brain was gone because she was completely, all the sugar was removed from her body. So yeah, insulin is not innocent, but has been around for a long time, and people can be educated to how to use it and that kind of stuff.
all righty. For a high school student, is there a Delaware activity that you would recommend to gain experience, other than mini medical school, of course?
I would say volunteering. You know, the hospitals, they always need somebody, you know, pay help, BB, you volunteer. And little by little, you move yourself up. People get to know you, you know, they see that uh, you like to provide a service, and you will be taken into consideration, and you can move little by little. And in the environment, you will learn, you know, you can learn from osmosis, you know, you're with people that know a lot, and something you learn just by being close to these people.
And then a related question is, do you recommend doing research internships during high school?
Yeah, I think that would be a great idea. Of course, if that's not gonna have a negative impact in your grades, because remember, you're gonna be competing with other kids that, you know, may have very good grades, and then you don't want that to affect that. But definitely, that would be a good idea.
All righty. And then in particular, there's a question about, do you think volunteering in a nursing home would be beneficial?
Yes, um, I would say yes, but how can I say this? In the nursing home, probably you're gonna be exposed to uh, many chronic conditions, uh, but also with some conditions that require the people to be there, and it will be, unfortunately, uh, static. It's helpful, definitely, and you can learn, definitely, definitely, in any environment uh, where, you know, health is delivered, you can learn, you know, yeah, for sure.
Yeah.
But then at some point, if you can move to a hospital, a clinic, it will be also great.
Yeah, I did my early volunteer work in 10th, 11th, and senior in high school at the Alfred I. DuPont Institute, now called Nemours. And you know, at way back then, we won't talk what decade that was, but way back, they were a pediatric, so a children's orthopedic, so musculoskeletal hospital, and they were renowned throughout the world as being the place where very complex cases came, and they were often very sad, and you know, very, very complicated, long surgical procedures, and it it definitely exposed me to a lot of neat things, but it also uh, somewhat biased what I thought pediatrics was, and what the pediatrics that they did there is not what pediatrics is more generally. It was a very specialized form of pediatrics. Uh,
What was it? What was the name of that doctor? Was the director of pediatric ortho? He was brilliant. You remember?
well, there was Dr. McEwen, Dr. Warren, Ferris. I mean, there are
Yeah,
a
yeah.
whole
It was
bunch of them. Yeah,
well. Now that now that you mentioned that experience that you had, I wanna emphasize that any experience is good. You know, if you are in this environment, nursing home, a clinic, a hospital, even in the orthopedic, like Tim, you know, it's good. But let me tell you, I'm going to take this moment just to tell them, the audience, that, you know, as I explained at the beginning, that the medicine can be divided based on the setting, as ambulatory medicine, inpatient medicine, ICUs, etc. It's also good. Maybe this can be helpful to understand that we also can divide medicine into uh, 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 medical problems and surgical problems. And it is important to understand these two different concepts, now, medical problems and surgical problems. Like, for instance, what I do, I take care of general medicine, medical problems. Let's say, like, for instance, to give an example, if a person trained to become a cardiologist, this person going to deal with the medical problems of the heart, the problems that he can fix with medicine. Of course, now we have intervention cardiologists, but in general, that's what it is. They take care of the heart through, you know, medical means, medications. But then there is another doctor who also take care of the heart, but that one is the one that operates the heart. This is a cardiovascular surgeon. This person deal with problems of the heart that are taken care of through a surgery, you know. And the same, you have, for instance, a nephrologist, which is a medical doctor of the kidneys. He knows the ins and outs of the kidneys, and he take care from the medical standpoint of the kidneys. And those are the one who manage the dialysis units too. All this is medical. But then you have, those are the nephrologists, but then you have the urologist, which is a doctor that take care of the genitourinary system from, there are many diseases that he take care of, but he also take care of the diseases that require surgical intervention, you know. So I just want to say that, I want to throw that because you mentioned about, you know, when you went, you did the rotation, and all of a sudden you were more in ortho, and you maybe were thinking, like, hey, what's going on in here? Where are the patients that are, you know, pediatrics, just pediatrics or something? Anyhow,
No, and thank you. That was an excellent explanation for those two fields. One might argue that there's a third that we're paying more and more attention to, and it's not just psychiatry, but it's behavioral health. It's understanding, you know, that overarching mind-body connection that drives us towards certain behaviors that you know, either make us sicker or help us get better. And you know, that's where public health gets involved.
That is correct. And you know, we have behavioral medicine here, and we need to have them because there is a shortage of psychiatrists, right?
Yeah.
For you to be seen, to see, for you to get a psychiatric appointment is extremely difficult. You know, we have here at Lared, we have a team of people that are nurse navigators. You know, we have referral coordinators. Those are one of the beauties that we have. So, for instance, I need a gastroenterologist. So I send a message to one of my referral coordinators, and they will actually do the appointment for the patient. They will navigate the system to try to make it a little faster. They say, hey, listen, I need this doctor to see this patient, you know, because patient has hepatic steatosis and, you know, fibro score is high, and I think patient is going to liver cirrhosis and whatever. So she will navigate the system faster than the patient. And we also have nurse navigators that are only for oncology. They are our second pair of eyes, which are extremely important because you know that you can miss an appointment, you can miss a diagnostic, and they are there to help us and also to assist us into navigate the system faster. If I want an oncologist, a hematologist to see one of my patients. So, yeah, again, I mean, we have a lot of stuff here for all of you.
Right. Ruth asks, when would a primary care doctor take a patient off of a medication for a condition like hypertension? When would they take them off, not put them on?
Okay, well, unfortunately, there are conditions that we cannot cure. In fact, there is a lot of conditions that we cannot cure, right? We cannot cure asthma. We cannot cure COPD. We cannot cure diabetes yet. We cannot cure hypertension. So some of these diseases we control. And we control through medication, through healthy eating habits, exercise, prevention. Now, a patient with hypertension, I'm going to give you an example, that is, let's say, obese, and the patient loses weight, and the blood pressure drops, and his healthy eating habits changes completely. And all of a sudden, the blood pressure is a little bit below normal, his medication. We can give it a trial and say, okay, let's stop the medication, see what happened. I know people that have been off medication because they have, you know, commit to his lifestyle changes. But it's not that easy. Most of us, you know, unfortunately, doesn't have necessarily this power to commit that way. I have also patients with diabetes. These are, I know I have two patients in the 300 pounds with a lot of medications for diabetes. These two men, they don't know each other. They lose to the weight that they were supposed, a little bit below the weight that they were supposed to have, and they are off medication. Nothing. Now, they have diabetes in my book, but the treatment is no medication, just the lifestyle changes, the exercises. It can happen. You can be off certain medications. Not always happen, but it can happen.
I think another thing that's worth pointing out in particular in talking about uh, high blood pressure is that there are a lot of different types of drugs that address high blood pressure in different ways. And if I'm not mistaken, the beta blocker class can also help with heart arrhythmia. Did I get that right?
Yes, you got it right. Yeah,
Woohoo!
yes. Beta blockers are some of the cornerstones of the management of a condition called heart failure, which
Right.
is, as the name says, the heart is not pumping properly. And the beta blockers came to change that for sure.
Right, right. Okay, a last and wonderful question. What do you think about glucose monitors for a person with pre-diabetes? And I'm going to amend that to say, what do you feel about glucose monitors for anyone? Since a lot of people who aren't even pre-diabetic have slapped them on as part of their body tracking biometrics that they do with their Fitbit and their smart ring and all the other stuff. But what do you think about those?
Well, I don't know that if in the future, people doing studies can come with something like that, but at this moment, there's no indication of monitoring a pre-diabetic patient. The pre-diabetes, the recommendation at this moment is to check an A1C once a year. And education, education, education. Because a pre-diabetic doesn't have diabetes. It's a person that, is couple of steps away from becoming, but if a person is educated about it and decided to change to adopt a good lifestyle, stay away from carbs, exercise, he can be pre-diabetic forever. Now, there are new ways to monitor the blood sugar in diabetic patient, and I'm specifically talking about this system like the Libre, for instance. The Libre, their system is excellent because it has not only tells you in real time, because the Libre 3 now tells you in real time how is your blood sugar, but also by you knowing in real time how is it, you get a feedback education about what you should avoid. And then, like for instance, it's not the same that you have diabetes and you know that you should not eat this bag of, of chicken fries, right? French fries. I'm sorry, you should not eat this bag of French fries, but you eat it. You don't know, you don't see anything. But if you have the sensor, you have the liver tree, for instance, and you eat it, the blood sugar gonna go 300, and then you will say, "Oh my gosh!" And then you go and you eat a piece of steak with salad, and your blood sugar remain about the same. So then you start to realize, you can in real time that if you eat proteins, your blood sugar not gonna go up. But if you eat carbs, it's gonna go sky high. So this is one of the beauties of these new monitors in real time for people with diabetes. This is not an advertisement like the Libre 3.
Right. Well, and I think arguably, especially for people who are using glucose monitors, like you see people who have them on the back of their arm who are, you know, uh, health aficionados. They're at the gym every day and they're running, and the whole thing. You can get into a loop of watching your own telemetry too closely and stressing yourself out. So a lot of it depends on what type of person you are and understanding how it's going to impact. I remember vividly, what was it, 20, 25 years ago, when we could start delivering patient telemetry directly to a physician's, personal digital device and whatnot. They were very quickly realized they didn't want up to the minute updates on what a patient's blood pressure was. It was too much information. So there's sort of a balance there between, a good amount and a bad amount. Just like we talk about how often should you weigh yourself if you're in a weight loss program. Well, if you're weighing yourself multiple times a day, you're probably going to frustrate the dickens out of yourself.
Absolutely.
Yeah.
Absolutely. Yeah. Not a good idea at all. And
Right.
in one line, in terms of the weight problem, which is an epidemic, um, you know, the obesity is a disease. It needs to be seen as a disease and recognized as such. And the people who have obesity, they have not obesity because they are lazy or because they don't have a strong will or none of those things. We know now that in the body, for instance, there is two opposing hormones, and one is leptin and the other one is ghrelin. And the ghrelin is a hormone that stimulates you to eat. And this is what happens if you start to lose weight. The body sends that as a insult to the body, as a threat, right? You're losing weight. So what the body does, the body triggers ghrelin. And the problem is that this ghrelin can be up to a year up. That's why multiple mechanisms, people that are obese, they start to work out and do their things, and they lose weight, but they plateau. And then they get frustrated because they were doing the same thing, but now they're losing weight, and they start to eat again. Two things has happened. One, the ghrelin has been activated. The mechanisms of satiety are blocked, but also the body, interestingly, the body become more efficient at not expending energy. So the energy expenditure of the body decreases because the body become more efficient. So then you don't lose weight that easily. On top of that, you're hungry now. So you need to understand those things. That's why it's important, the education, right? Because when you have a patient like that, and you explain this, you say, listen, when this happens, it's going to happen. You're going to plateau. But if you understand that this is a mechanism of preservation of your body, then you're going to double down on what you're doing. And then eventually you're going to drop again. But usually people get frustrated, and but obesity is a disease,
Yeah.
a disease.
Well, and the behavior modification that it takes, the commitment to maintaining exercise, maintaining eating the right things. Just learning that behavior, really almost creating like a muscle memory for that behavior, takes a long time to get there. And it takes, for most people, very little to break it. And frustration is a really good breaker
Absolutely.
of
Absolutely.
behavior. Well, doctor, this has been awesome. Thank you very much, everyone. We will not see you next week. Happy Thanksgiving. We will see you the following week. Everybody have a great evening. Take care.
Thank you, Tim and Christy, for having me. Thank you very
Thanks
much.
for coming. We appreciate it.
Okay.
Bye-bye.
Bye-bye.